Welcome to an IA PMD professional community webinar. Our monthly cycle science webinars are led by experts in the field. Today's session will be covering how to study the menstrual cycle, practical tools and recommendations, and we are joined by Dr. Katja Schmalenberger.
It gives me a lot of pleasure to introduce Katja. So I met Katja. This is actually the person who I spoke about last time when I was talking about how important having a community of cycle scientists was to me, because she was really the first person who was as excited about this stuff as I was. And she ended up working with me throughout her PhD remotely from Heidelberg, Germany. So now she has defended her dissertation. She's an incredible menstrual cycle scientist, really thorough, really thoughtful, really nice, and really brilliant. So she's right now a postdoctoral fellow at Heidelberg University Hospital in gynecologic psychology, sorry. She's a clinical advisory board member at IAPMD, so she serves with us as a volunteer here. And then she's also, in addition to being a scientist in this area, studying the menstrual cycle primarily, she's also undergoing some clinical psychology training so that she can provide evidence-based care for patients who are suffering with emotional disorders as well. So she's a really well-rounded, wonderful person. Please welcome me and virtually joining Dr. Katja Schmalenberger.
Thank you so much, Tory, for this nice introduction. And thank you to everyone at IAPMD for putting together this exciting course of webinars and this scientific community. And I'm so excited to speak today and give a talk on how to study the menstrual cycle and to present the practical tools and recommendations that we recently published. But most of all, I'm very excited about discussing these recommendations and tools with you. So use the community chat and tell us what you think. And later on, let's discuss this. Okay. So. To give you a sense of what I will be talking about today, you can see our agenda here. Tory already introduced me, which is so nice. Thank you so much, Tory. And we will dive right in with a quick overview of the menstrual cycle and premenstrual disorders, and then we will talk about our recommendations on how to collect data in menstrual cycle studies, how to prepare and code that data, and how to visualize and statistically model that data. So we can roughly divide the talk into two parts. First, the more theoretical considerations, and second, the hands-on practical recommendations and guidelines. You can find everything that I will be talking about today in this article that we published at the beginning of the year in Psychoneuroendocrinology. Basically, I will review the paper and its appendices for you today and try to give you a thorough overview of all the recommendations and tools we provide. When doing so, you might want to keep in mind where my wonderful co-authors and I came from when we developed these recommendations. We are all clinical scientists interested in hormone effects on the brain and behavior. So what we are interested to find out today is, are these guidelines applicable to your field as well? For example, are they helpful if you're studying endometriosis or dysmenorrhea? That is why this scientific community is so great. We need a place to civilly disagree on this and discuss this. Because, and I cannot stress this enough, we consider these recommendations and guidelines to be a starting point for refinement, for specialization, and for improvement. And as you will see later on, there are still so many unanswered questions and so much more research is needed. But with this paper, we have, like I said, a starting point that also offers a unitary vocabulary that will hopefully ease discussions. So let's improve this and build upon this together. But first, let me review it and introduce it. Okay, so we will begin, like I said, with a short overview of the menstrual cycle and everything that happens on the hormonal, follicular, and endometrial level. Each menstrual cycle starts with the onset of menses, which is the shedding of the endometrium, as you can see on the bottom of the graph. On the hormonal level, both ovarian hormones, estrogen, or short E2, and progesterone, or short P4, are low. Since the developing follicles produce E2, E2 levels are slowly rising in the so-called follicular phase and peak right before ovulation. After ovulation, which is the release of the oocyte from the dominant follicle, the remains of the follicle turn into the corpus luteum and the luteal phase begins. The corpus luteum produces P4 and D2 and is therefore responsible for the peaking levels of both hormones in the mid-luteal phase. If the oocyte is not fertilized, the corpus luteum involutes, which causes rapid withdrawal of E2 and P4, and this withdrawal in turn triggers the shedding of the newly built endometrium, and with the next menstrual onset, a new cycle begins. Due to the predictable lifespan of the corpus luteum, the luteal phase has a more consistent length than the follicular phase. As the meta-review by Fehring and colleagues suggests, the average length of the luteal phase is 13.3 days, whereas the follicular phase generally lasts 15.7 days. However, as you can see by the confidence intervals, the luteal phase shows variability in length as well. Its confidence interval is shorter than the one of the follicular phase, but it is still 9 days compared to the 12-day confidence interval of the follicular phase. So let's keep that in mind. And let's also not forget that healthy menstrual cycles, in the sense that they are ovulatory and would support a pregnancy, can last between 21 and 37 days. So now that we know what happens across a natural menstrual cycle, let's think a little bit more about for whom and why these fluctuations of E2 and P4 can cause problems. As we robustly know from observational and experimental studies, the majority of women do not show clinically significant cycle-related changes in their emotional and/or cognitive functioning. Rather, it is only a subset of naturally cycling individuals suffering from clinically significant emotional, cognitive, and behavioral symptoms. Seminal experimental research revealed that these symptoms are not caused by abnormal ovarian hormone changes, but rather by an abnormal sensitivity to normal changes of ovarian hormones and their metabolites across the menstrual cycle. And this so-called hormone sensitivity can manifest as a primary cyclical mood disorder, which is basically premenstrual dysphoric disorder or short PMDD, or in perimenstrual exacerbation or short PME of a chronic underlying disorder, for example, depressive disorders. It is very important to keep these inter-individual differences in the neurobiological sensitivity to the menstrual cycle in mind when you start to think about data collection in your study. Given that individuals highly differ in their vulnerability to cyclical symptoms, the menstrual cycle is fundamentally a within-person process and should be treated as such in clinical assessment, experimental design, and statistical modeling. For this reason, repeated measures studies are the gold standard approach to cycle research. With this being said, it is important to note that when you design a repeated measure studies, there is not one right way to select the number and timing of assessments. When thinking about what is the best for your study, we recommend to first consider what the purpose and the hypotheses of your study are. What design is required to achieve these goals? For example, if you're interested in cyclical change of self-reported effective outcomes, you may wish to do daily or multi-daily assessments. Researchers, in contrast, researchers hypothesizing an interaction between E2 and P4 in the prediction of, for example, HRV, heart rate variability, may wish to assess HRV in the mid-follicular, the peri-ovulatory, and the perimenstrual phase, as is shown in red. In contrast, researchers hypothesizing a positive association of E2 levels with performance on a computerized cognitive task may wish to sample at least in the mid-follicular and in the peri-ovulatory phase, as is shown in blue. And if you're interested in P4 effects on your outcome, you may wish to sample in the mid-follicular and in the mid-luteal phase, as is shown in green, and so on. So you can see it really depends on your outcome and on your hypotheses in which cycle phases you should schedule your assessments. And second, you should also consider statistical approaches in advance, noting that the number of observations that may be required to model variance appropriately may differ. Given that the most reasonable basic statistical approach for analyzing menstrual cycle data are multi-level modeling approaches, which require at least 3 observations per person to estimate random effects of the cycle, 3 repeated measures of the outcome across one cycle could be considered the minimal acceptable standard for estimating within-person effects of the menstrual cycle. In general, it is best to have as many assessments as possible. However, when repeatedly assessing psychophysiological or task-based outcomes, for example, cognitive tasks, possible order and training effects should also be considered. So as you can see, a thoughtful selection is very important, but repeated measure studies are the gold standard, and we definitely recommend that. So next to these considerations on the timing and number of assessments in your repeated measure studies, you should carefully consider who to recruit in order to test your hypotheses. If you are in need of a hormone-sensitive sample, keep in mind the between-person differences in the sensitivity to the cycle. Drawing from small convenience samples is unlikely to provide enough statistical power to investigate individual differences and yield clear conclusions. So we suggest 3 different approaches to identify hormone-sensitive individuals. First, studies could identify them via prospective data collection of cycle-related psychiatric symptoms. Cyclicity in symptoms then indicates hormone sensitivity. Alternatively, when sampling from the general population, the sample should be large enough to observe and statistically model between-person differences in hormone sensitivity. Keep in mind that the prevalence rate of PMDD is about 5.5%. When thinking about how big your sample needs to be so that you have enough hormone sensitivity individuals in there. A third option is to over-recruit based on factors shown to be associated with the severity of hormone sensitivity. Among those are, for example, historical exposure to extreme stress, recent stressful life events, current stress, impulsivity, and features of borderline personality disorder. And we have some examples of studies who did just that on the slide, and of course in the paper. So once you landed on a study design and recruitment strategy, you might draft recruitment materials. And when doing so, we recommend that researchers take care to reduce demand characteristics of their studies. Note on recruiting materials that people with menstrual cycles can experience positive, negative, or no hormone effects. And we want to stress this as many menstrual cycle studies have been rightfully criticized for implying that all females experience perimenstrual impairment in function. Okay, so let's assume that you want to enroll participants into your study now. It's very important to carefully assess their reproductive status, for which we provide this tool, the reproductive status questionnaire. It looks very long, but it is actually not that long. It's a short questionnaire that can probe developmental state of the reproductive organs and general level of ovarian hormones in order to determine if an individual is normally cycling and therefore suitable for study participation. And we also provide helpful notes, or at least we hope they're helpful, for researchers next to the questions, and I highlighted them in green. And ideally, you would the questionnaire would be repeated at the beginning and at the end of the study in order to detect any changes in reproductive status that may have occurred during study participation. If you have a very long study that lasts 6 months, then maybe there were some changes in those 6 months. So let's take a brief look at what the questionnaire assesses. First, we strongly recommend that researchers take care to conceptually separate biological sex from gender identity. The first questions therefore inquire about gender identity, preferred pronoun, biological sex assigned at birth, and which reproductive organs are present at the time of the assessment. And we strongly encourage inclusivity of all gender identities, as many cycle studies receive valid criticism for overvaluing identification with female roles. Next, the questionnaire tackles menarche and menopause, the 2 bookend reproductive milestones for the fertile phase of life, during which females typically experience regular and ovulatory menstrual cycles. However, the phases surrounding these milestones are characterized by irregular cycle lengths and increased anovulatory cycles, or an increased number of anovulatory cycles. Studies focusing on the regular cycle or ovarian hormones should therefore utilize caution when including participants near these 2 milestones. And we provide recommendations on how to do so here. For example, we state that if the participant experienced menarche within the past 3 years, the cycle may not yet be regular enough to qualify for study participation if you're interested in the effects of a natural regular menstrual cycle. Similarly, we provide recommendations regarding pregnancy and breastfeeding, which both suppress fertility and thus a regular menstrual cycle for a variable time. As breastfeeding declines, regular menstrual cycles resume. However, the first few menstrual cycles are generally unlikely to support a pregnancy due to low production of P4 by the corpus luteum. We therefore recommend participants experience at least 3 menstrual cycles post-breastfeeding before participating in menstrual cycle research. Next to menarche, pregnancy, and menopause, hormonal medications, while administered for various reproductive and non-reproductive reasons, may alter the natural menstrual cycle. Their use should be carefully assessed when recruiting potential study participants. This is why we included several items to the questionnaire which help to determine whether study participation is possible for participants on hormonal medications. And finally, you cannot see this on this slide, but the reproductive status questionnaire also obtains a complete list of medications to determine potential impact on cyclical mood changes. For example, if the person takes SSRIs, and this might be important to your study and your hypotheses. Okay, so now that you have characterized your sample of naturally cycling individuals and start data collection, we always recommend assessing all menstrual bleeding dates during and surrounding study participation. This can be achieved with very low cost, for example, with this 3-item survey. And this survey assesses the start date of the with this survey, you can assess the start date of the previous menses and then the start date of the following menses, and then you can approximate position within an individual's menstrual cycle. But we will get to that in more depth in a little while. So next to these menstrual bleeding dates, you might want to measure ovarian hormones and associated substances. For example, the luteinizing hormone LH or the follicle stimulating hormone FSH. Sorry. Okay. So both LH and FSH show systematic variations across the natural menstrual cycle, including a singular pre-ovulatory peak, as you can see here. LH in blue triggers oocyte release by the dominant follicle, which is ovulation. And given that ovulation typically occurs 10 to 12 hours after the LH surge, LH testing is traditionally used to determine if a menstrual cycle is ovulatory and when ovulation occurs. In research settings, commercially available home urinary LH tests are frequently used. And LH can also be measured in samples of blood serum and plasma. If you decide in your study on using urinary LH testing with test stripes, and you use tests where participants must compare the control line with the test line to obtain a result, you may increase reliability by requesting that participants electronically send photos of each test for verification. And if you have the financial resources, then we really recommend that you use standardized interpretation of the ovulation tests, and we recommend that you use the more costly tests delivered with electronic readout. In contrast to LH, measuring basal FSH levels on cycle day 3 in premenopausal women is traditionally used to evaluate ovarian reserve, which can clarify fertility and infertility issues. And given that general FSH levels demonstrate a significant increase near perimenopause, FSH testing is informative on menopausal status as well. Okay, so next to LH and FSH, you might also be interested in measuring progesterone P4 and allopregnanolone, or short allo. Across the natural menstrual cycle, P4 is mainly produced by the corpus luteum in the luteal phase, as I mentioned before. And since anovulatory cycles show no changes in P4 levels, a luteal increase of P4 validates the occurrence of ovulation and marks the start of the luteal phase of an ovulatory cycle. P4 levels can be measured in samples of urine, saliva, blood plasma, or blood serum, each of which offers various sampling advantages and disadvantages. We could talk about this for the whole webinar, but in short, drawing blood for research requires high-cost preparations, such as highly trained personnel, facilities capable of disposing of biohazard blood, and protocols for managing risk, like fainting or bruising, which can sometimes rarely happen. In contrast, both saliva and urine sampling can be conveniently done in almost any research environment. However, saliva sampling does require potential disruptions to the participants' daily routine, like no smoking or no soft drinks in the hour or the 2 hours before saliva sampling. And this in turn requires a high level of compliance from the participants. But assuming excellent compliance, studies suggest a high correlation between salivary and serum levels of P4. However, more research is definitely needed here. And in general, we recommend weighing relative advantages and disadvantages of each method for each study. An increasing body of research suggests some effects of P4 may be mediated by its neuroactive metabolites, among which pregnenolone and allopregnenolone, or short allo, are the most studied. These neuroactive steroid metabolites modulate the GABA system by acting as positive allosteric modulator of GABA A receptors. And while their common effect is inhibitory, studies suggest that a small subgroup of naturally cycling women have adverse effects like negative mood, anxiety, irritability, or aggression upon exposure, which is a very interesting line of research. And allo can be measured only in blood serum samples. Okay. Shifting from P4 to E2, we have a lot of similarities, especially regarding the measurement. As we talked about before, the rise of the dominant follicle results in the mid to late follicular spike of E2, which is followed in 24 to 37 hours by ovulation. The E2 spike is therefore well suited to determine if and when ovulation happens. And similar to P4, E2 levels can be measured in samples of urine, saliva, blood plasma, or blood serum. In contrast to P4, there is some evidence that serum and saliva E2 fail to correlate, while more recent studies suggest salivary E2 assessments to be an adequate estimate of serum E2. And again, a lot more research is needed. Oh, sorry, I was a little bit too fast. Okay, so a lot more research is needed on estrogen and salivary and serum estrogen, and the same goes that a lot more research is needed for the basal body temperature, or short BBT, which is defined as the body's lowest temperature at rest. BBT shows a biphasic pattern across the natural menstrual cycle. It is low across the follicular phase, demonstrates a nadir before ovulation, increases sharply at ovulation, and then remains high across the luteal phase. When compared against LH testing methods, 210 biphasic assessments showed BBT nadirs occurring within 1 day of the urinary LH search in 75% of cases, and within 2 days in 90% of cases. And given that only a sustained temperature rise confirms the luteal phase, BBT is considered most accurate for the retrospective identification of the peri-ovulatory phase. And for research purposes, BBT should be collected every morning before arising across a complete menstrual cycle. Participants can utilize commercially available oral or vaginal BBT thermometers and note their own results, or they can continuously wear devices like a wristband or a finger ring with integrated thermometers that record BBT measures during the night and save them electronically. Several factors should be considered when deciding whether to use BBT assessments or LH testing for determining ovulation in a given study. First, one must consider the focus and the design of the study. For example, if it is necessary to immediately know about when the LH search, that is ovulation, is happening, so that the study team can schedule a peri-ovulatory lab visit, LH testing is required, since BBT does not allow for confirmation of ovulation timing until much later in the cycle, because you need the sustained rise in BBT. However, if it is sufficient to retrospectively validate that the cycle was ovulatory, BBT assessments are a suitable choice. And then, of course, consider costs, accuracy, feasibility, and burden for the participant for each method in order to make a thoughtful selection that will facilitate the best possible science. But also, given the rapidly evolving landscape of biomedical technologies, we should definitely keep an eye on BBT, and we should investigate its use in cycle studies more thoroughly. Might be useful to start with calculating a cycle day variable for each observation. Here you need to know the date of the previous menses onset, the date of the subsequent menses onset, and of course the date of your observation. And in order to get your forward day counting cycle day variable, you count forward from the onset of the previous menses, which is day 1 until your observation. And for your backward day counting cycle day variable, you count backwards from the onset of the subsequent menses. And you will need these cycle day variables when you get to the next step, which is the coding of menstrual cycle phase. The study of menstrual cycle phases typically aims to test hypotheses about the impact of discrete hormonal events on outcomes of interest. However, methods used to determine these phase variables differ widely between studies. And this is why we propose this set of cycle phases that we found to be most commonly used in the literature, and or that we found to be theoretically make the most sense since they capture hormonal events. And for each cycle phase, we provide several methods of phase coding based on the just mentioned forward and backward count day and based on ovulation-based methods. We also give recommendations for each phase, which of these phasing procedure is the most precise one. And it is very important to note here that there is not one best way to cycle phase. Rather, you should understand the pros and cons of each cycle phasing definition and approach, and then choose the one that is most suitable to your study and hypotheses. And again, this is a starting point, and let's discuss this, but this is what we propose. This impressive graph provides an overview of all the different cycle phases that I will briefly introduce in the following. But so let's dive in and take a closer look. And first, we recommend these 4 phases for investigation in empirical studies: the mid-luteal, the perimenstrual, the mid-follicular, and the peri-ovulatory phase. These phases are characterized by clearly delineated hormonal events rather than relative changes in hormone levels. The mid-luteal phase is characterized by high and stable E2 and P4. The perimenstrual phase is characterized by falling and low E2 and P4. The mid-follicular phase is characterized by a slight rise in E2 and low P4. And the peri-ovulatory phase is characterized by a strong rise and fall of E2 and a slight increase of P4. For the mid-luteal, the mid-follicular, and the peri-ovulatory phase, we recommend ovulation-based methods to determine them, as is indicated by the 1 in the table and these little stars. So it is more visible. So here we use the positive LH test or the BBT nadir as a reference and instruct on how to count forward and or backward from these confirmed dates of ovulation. And in case of the perimenstrual phase, ovulation-based methods do not apply, but we propose a combination of forward and backward counting from the onset of menses. In some cases, investigators have specific hypotheses regarding E2 surges prior to ovulation versus high levels of E2 during ovulation versus falling E2 post-ovulation. And in such cases, then we have the pre-ovulatory and the post-ovulatory phase. In such cases, the use of either daily E2 levels or daily LH testing is defensible to pick out 2 pre versus post-ovulation days for comparison to other phases. Roberts and colleagues, for example, found that among females with ADHD symptoms increased in the post-ovulatory versus the pre-ovulatory days, which may indicate that falling E2 is impairing for cognitive functioning among hormone-sensitive individuals. So more work is needed to flesh out these methods, but they are reasonable when either LH testing or E2 levels allow clear determination of the E2 peak. Counting methods do not apply here. If you're interested in pre versus post-ovulatory days, then you definitely have to do ovulation testing. Regarding the cycle phases, menstrual week and premenstrual week that you can see here, we recommend to use them with caution, which I want to explain now. It is important to note that these time frames are defined by their relative position to menstruation rather than with reference to a measurable hormonal change or status. Therefore, it is only defensible to use these phase designations if the study aims to understand events in relation to the premenstrual week or menstrual bleeding, rather than in relation to hormonal events. However, since the study of cycle phases generally intends to test hypotheses about the association of discrete hormonal events with outcomes, it is usually advisable to code the phases surrounding the onset of menses such that they focus on hormone changes, as I just described is the case for the midluteal, perimenstrual, and midfollicular phases. For this reason, we recommend the use of these two phases only in rare instances, and we consider counting methods starting from the day of menstrual onset as the most appropriate phasing procedures. Okay. Systematic reviews of menstrual cycle research show that many studies draw comparisons between the two halves of the cycle, that is the luteal and the follicular phase. However, many different hormonal events and levels characterize the follicular and the luteal phase. The influence of a particular hormonal event on the outcome of interest cannot be accurately assessed by these two broad phases, and effects themselves may be washed out by dynamic changes within each phase. So thus, this method of coding is not recommended, for empirical studies. Nevertheless, due to its prevalence in current literature, we provide a brief overview of the best phasing procedures here. Okay, so now that you have settled on your cycle phases, you are technically ready to test your hypotheses, for example, about the impact of discrete hormonal events on your outcome of interest. However, prior to your hypothesis testing, we recommend graphing the effects of the menstrual cycle on the raw outcome and the person-centered outcome. You can do this for each person individually, as you can see here in the so-called spaghetti plot, and for the group as a whole, as you can see on the right. This will help you detect potential outliers or patterns of relevant to later modeling strategies. Generally, the person-centered approach is based on generating an individual's mean across all observations and subtracting that mean from each individual observation. And this results in a repeated variable that represents how each observation stands in relation to the individual's typical level of that variable. That means how much lower than one's mean or higher than one's mean is that particular observation. And person-centering the outcome variable is recommended for visualizing menstrual cycle effects because it allows researchers to observe pure within-person variance across the cycle, which may be obscured by between-person variance in raw outcomes. So, for example, let's take a look at this spaghetti plot on the left. Each line is a person, and the y-axis displays daily anxiety, and the x-axis displays person-centered estrogen. So while one person, for example, this person, has lower anxiety when they have lower than usual estrogen and higher anxiety when they have higher than usual estrogen, this person has higher anxiety when they have lower than usual estrogen and lower anxiety when they have higher than usual estrogen. So we see a lot of within person variability here that this spaghetti plot is perfect to display. In the example on the right, we can see person-centered daily interpersonal conflict on the y-axis, and on the x-axis, we can see a cycle day variable ranging from day -15 to day +10. And we can see that the sample shows lower than usual interpersonal conflict in the ovulatory phase and higher than usual interpersonal conflict in the perimenstrual phase. So let's think a little bit more about displaying the outcome across this cycle phase, this cycle day variable that ranges from day -15 to day -10. We actually recommend presenting your outcome like this for several reasons. So you can see this theoretically here, the hormone changes that we would expect from day -15 to day +10. And then we can see this example from this one study on interpersonal conflict. So why do we recommend to display the outcome like this across this cycle day variable. First, the cycle day variable from day -15 to +10 ensures transparency with respect to all potential patterns in the data. Also, it allows other scientists to draw their own conclusions about the impact of the cycle on the outcome. And finally, it reduces the risk of reviewer bias in selecting cycle phase definitions that maximize the size or statistical significance of their findings. So we provide step-by-step instructions for coding menstrual cycle day in any statistics software, and we provide it in the appendix of the paper that I showed you before. And it should be noted that that this variable creates an intuitive timeline relative to menses onset, such that day -1 is the day before menses onset and day 1 is the day of menses onset, and there is no day 0. And although the omission of day 0 on the timeline for cycle phase coding may cause confusion, it is preferred due to the strong and intuitive tradition of labeling the first day of menstrual bleeding as day 1 of the cycle. Okay. So let's move on from visualizing menstrual cycle effects to hypothesis testing. As we already talked about before, there are large between-person differences in responses to the cycle, which is why analyses should allow for the modeling of between-person differences in within-person change across the cycle. And the most commonly used method that meets these criteria is linear mixed modeling or multi-level modeling, which can be carried out in various statistical packages, including SAS, RStudio, SPSS, Stata, M+, or HLM. And one major benefit of multi-level modeling is that it allows for the estimation of both average cycle effects in the full sample, or so-called fixed effects, as well as individual differences in the size and direction of those effects, or so-called random effects. It also allows for cross-level interaction terms, that is the interaction of traits, for example, impulsivity and cycle phase. This can be used to identify which between-person characteristics might account for between-person differences in cyclical change. Strategies for operationalizing and modeling within person cycle effects can be categorical or continuous. So let's first take a look at categorical cycle phase contrasts. Examining within-person contrasts between cycle phases is one of the most straightforward methods of testing for cycle effects. In this approach, the within-person cycle phase variable is category coded such that there's a reference phase, and this reference phase allows for pairwise comparisons between the means of each cycle phase for a given individual. You then have to alternate the reference group to observe all pairwise cycle phase comparisons, as you can see here. You can see the alteration of reference phase. Random intercepts should be included to account for the nesting of each data point within a given individual and to model the degree of between-person variability in average values of the outcome. And random effects of each cycle phase contrast should also be included, except where a likelihood ratio test indicates that their inclusion significantly worsens model fit. And if it does worsen model fit, this would suggest that the sample is homogeneous with respect to the cyclical effect. So in contrast to these categorical approaches, the continuous approaches conceptualize the menstrual cycle as a nonlinear function of time. They model the cycle using this continuous cycle day variable that I just talked about, from day -1 to +10. The only thing here is, in order to do the analyses, days +1 through +10 should be recoded as days 0 to +9 in order to eliminate the single day gap between days -1 and day +1. As you can see here in this example, suddenly we have day 0 and it only goes up to day 9. In this example, a quadratic effect captured the typical perimenstrual rise and postmenstrual fall of symptoms among hormone-sensitive individuals. Generally, these continuous approaches are more complex than the categorical contrasts and can be difficult to correctly specify. However, they are very promising, but as of yet untapped options for characterizing the temporal dynamics of the association of hormones or cycle phases with symptoms. So we definitely wanted to introduce them as well. But whether you use continuous or categorical approaches, it is important to consider modeling between person predictors of within-person cycle effects. And here you generally have two options to do so. You can use top-down, hypothesis-driven approaches and specify a moderator of within-person cycle effects using these cross-level interactions in multi-level modeling that I just mentioned. And here, the authors use sensation seeking as a moderator of within-person cycle effects, or you can use a bottom-up approach to derive unique groups of change across the cycle, using, for example, group-based trajectory modeling. It basically looks for clusters in the data, bottom up. And here we found 3 clusters of symptom change across the cycle. So this is something to keep in mind as well. You can go top down or you can bottom up. You can go bottom up. So whichever approach fits your study and hypotheses the best, at some point you want to interpret your results. And we could talk about this the whole webinar on how to interpret results, but we just, it's a very complex topic. However, we wanted to make 2 general remarks here. First, we want to note that significant effects of the menstrual cycle should be regarded as correlations rather than evidence for causation. Only experimental manipulation of specific aspects of the cycle can demonstrate true effects of the hormone levels or changes on outcomes, as, for example, Schmidt and colleagues did. Our second remark concerns lagged effects of hormonal events. It is tempting to assume that finding an association between an outcome and a particular cycle phase implies that the concurrent hormonal events drove the symptom change. However, at least with respect to symptoms of PMDD, studies suggest delayed effects of hormone change, such that the emergence of symptoms occurs in a different phase than the hormonal event. And this is why we generally recommend that interpretations of cycle correlations should emphasize the complex and often delayed nature of cycle pathways. And then when appropriate, studies should call for experimental tests to clarify the causal role of specific hormone changes in a given outcome. Okay, before ending my talk with a short summary, I want to take a moment and think with you about how to use menses start date and ovulation testing to schedule visits in lab studies. Because depending on the research question, studies can require participants to complete visits during certain cycle phases. And the several methods for determining cycle phase that I discussed above each have a unique applicability for scheduling visits. So first, analyzing hormone levels from blood or saliva is suitable only for retrospective validation of cycle phase, not for scheduling lab visits due to the cost and resources required to analyze the sample. Second, regarding the peri-ovulatory phase, the LH search method is the only suitable method to schedule a lab visit reliably. Given that ovulation happens 10 to 12 hours after the LH search, participants should perform 1 LH test per day, several days before the expected ovulation. Third, the LH search method can be used to schedule midluteal, premenstrual, or perimenstrual lab visits by adding a corresponding number of cycle days to the detected day of ovulation. And the same goes for BBT methods, which can retrospectively verify ovulation, and then you add the number of days to schedule lab visits in the midluteal and the pre or perimenstrual phase. Finally, for arranging menstrual and mid-follicular lab visits, a corresponding number of cycle days should be added to the reported day of menstrual onset, and this is basically the counting method. And with these approaches, you will most likely yield precise scheduling of lab visits, and that will help make your results more meaningful. Okay, before diving into our discussion, but I can see that the chat is really full, so you are hopefully discussing already. Let's quickly summarize what we've learned and what we've recommended so far. So first, when planning your study, start with a hypothesized mechanism, usually ovarian hormones, neuroactive steroid metabolites, and select phases and design based on that. Or, of course, use daily ratings. Second, consider between-person differences in the sensitivity to the cycle by either over-recruiting hormone-sensitive individuals or recruiting a very large sample. Third, Measure the cycle as a within-person variable and use a repeated measures design that fits your outcome. And then characterize your sample's reproductive status, for example, with the reproductive status questionnaire. Select the best possible method for cycle phasing, given your resources and questions of interest. Apply a statistical model that treats the cycle as a within-person variable that differs in its effect between people. And last but not least, visualize the full cycle using person-centered variables.
Thank you, Katja. That was awesome.
Thank you so much for letting me present this. It was so much fun. Thank you.